Moving on to the next segment of the day, which is a plenary on the gut-brain link to dementia. May I now invite Dr. Iranganaraguda and Dr. Prasad Sirivardhana on stage.
Good afternoon, everyone. Our next speaker is Dr. Karunya Kandimalla. He's a professor at the Department of Pharmaceuticals and Brain Barrier Research Center and Associate Dean for Graduate Education at University of Minnesota. He's going to talk us on the topic, the gut-brain link to dementia. Over to you, Professor.
Thank you for the kind introduction, and I really thank Dr. Suranga Malingama for inviting me to speak at the conference today. I've been having a wonderful meeting so far and enjoying the beautiful country and the hospitality of the kind people. And thank you for everything. So I would like to really connect two very difficult things to bridge. The gut microbiome and the dementia. So these topics are becoming very difficult because of the investments that are receding due to the risks involved. For example, I'm going to talk about Alzheimer's disease, which is now being considered as a graveyard for drug discovery scientists because many of the clinical trials failed. And several pharmaceutical companies have spent billions of dollars without really major successes in coming up with therapeutic alternatives. In case of gut microbiome, the challenge is quite different. So initially, when there were clear evidences that gut microbiome is indeed affecting the drug absorption, drug metabolism, and influencing the biodistribution, bioavailability of many drugs, pharmaceutical companies have become very nervous. You know, one CEO of a very big pharmaceutical company famously said that, when he was asked if gut microbiome should be added as a screen for drug discovery pipelines, he said, let them mess with their drugs. I don't want anyone to mess with our drugs because of the risk that is out there and how the gut microbiome could impact therapeutic outcomes. So in that perspective, most of the research has moved to primarily nutrition fields where people started investigating the impact of food on microbiome. But then because of the diversity of the food, it's getting extremely difficult to narrow it down to the causal factors. So with that introduction, now I would like to open it up and then raise more questions rather than answering some of them. But those questions, in the spirit of envisioning the future and empowering physicians, I hope are going to be very important and relevant questions. So let's get started. Okay, so just a brief introduction on the gut microbiome and the gradient of various bacterial expressions in various areas of the gut. So if you could see that in the stomach and in the small intestine, the presence of microbes in a healthy individual is extremely low compared to the microbes that are present in the colon, right? So that's very important. As the person is aging, the microbiota moves into small intestine and stomach and creates a lot of problems. So we want microbiota where it belongs and do its job by providing very essential nutrients that we cannot get from any other sources, right? So here you could notice that there is a huge difference in the orders of magnitude. In the small intestine, the maximum is about 10 to the power of 3, whereas in the colon, it's 10 to the power of 13. So it's a huge population of microbes that are present in the colon. So the colonic bacterial composition is very different than compared to anywhere else in the gut. And then colonic bacteria are strict anaerobes. So they actually help break down fiber that is indigestible and then provide really essential nutrients such as short-chain fatty acids. And I'm going to talk about those a little bit more as we move through our talk today. Now, the gut microbiome changes with aging. So if you consider various stages in human life, like right from the pregnancy to elderly individual, you could see that the population of microbes, the type of microbes, change dramatically. For example, at infancy, Enterobacteria is the primary species present in the gut, and after 6 months, it's Bifidobacteria and Bacteroides. Then at 24, it's Firmicutes and Bacteroides, right? So in adulthood, in an healthy individual, the Firmicutes increase in number and Bacteroides actually go down in number. But in elderly, it takes the other way around. So you could see that in elderly, there is a very, very clear demarcation in terms of dysbiosis. And dementia is primarily observed, and it's particularly, I'm going to talk about Alzheimer's dementia, where aging is a major risk factor. That's the reason why it's important for us to notice the shift in the microbiome as well. Okay, now coming to Alzheimer's disease, which is a devastating neurodegenerative disease of aging. Aging is the primary risk factor, right? So we have 1 in 6 patients or 1 in 6 individuals about 70 years of age at risk for Alzheimer's, whereas every other person above 80 is at risk. So aging is a major risk factor compared to anything else that we know of, right? So Alzheimer's is characterized by the change in the brain morphology. The brain shrinks. If you see it on MRI, the brain volume decreases significantly. And also there are white matter abnormalities. There are microbleeds. All those are regarded now as the major risk factors of Alzheimer's. But the classical hallmarks that you don't see in any other disease are the intraneuronal tangles, and then the amyloid plaques that are present in the brain parenchyma. So those are the classical hallmarks of Alzheimer's. Of course, first identified by Dr. Alzheimer's himself in the patient Alois Ditter. So the first Alzheimer's patient had these hallmarks, and even now, today, those are considered as the primary hallmarks of the disease. And now it's becoming more and more clear that cerebrovascular amyloid that primarily contributes to cerebrovascular pathology is also one of the most important hallmarks. Of course, it's not present in 100% of the patients, but in a wide majority of Alzheimer's patients, right? So again, to summarize, we have severe neurodegeneration, memory loss, parenchymal amyloid plaques, intraneuronal tangles, and cerebrovascular amyloid. Why is cerebrovascular amyloid important? If you look at the neuroepidemiological data, a clinical diagnosis is reached like based on the cognitive tests that neurologists could identify. For example, 70% of the patients as Alzheimer's are suffering from Alzheimer's. But once the subject passed away, and then when we have information from the autopsied brain, you have a significant diversity in terms of classical Alzheimer's hallmarks versus vascular hallmarks related to vascular dementia. So now the pure Alzheimer's, clear Alzheimer's disease is only seen in 25% of the patients in autopsied brain sections, whereas most of the patients had mixed dementia. So where classical Alzheimer's versus vascular dementia. So that's when there is a lot of shift towards looking at cerebrovascular pathology, cerebrovascular risk factors. And indeed, NIH has started which is National Institutes of Health in the United States, started a big initiative on investigating the cerebrovascular contributions to Alzheimer's disease. And it is the cerebrovascular contributions that brings us very close to the consequences that are modulated by gut microbiome. Because gut microbiome generates soluble factors. Soluble factors will circulate in the systemic circulation and where the cerebral vasculature gets exposed to. And that's what could have a direct impact on the cerebrovascular pathology. Okay, so now I don't have to talk about this in detail, but I just want to remind you that endothelial function is the most predictable physiological event that's happening in the brain. So when a person even opens up the eyes, the visual neurons in the visual cortex starts firing. So those neurons are very hungry. They take up glucose. They need a lot of neurotransmitters. And then they also generate a lot of metabolites that need to be cleared because neurons are highly specialized cells. They don't have abilities to take care of themselves. They rely on supporting cells around them. And then they rely on endothelial cells, the blood-brain barrier endothelium, to supply them with nourishment, to remove those metabolites from the brain so that they're not piling up and causing problems. So in a way, cerebral vasculature maintains brain homeostasis. That's the reason why you could see the endothelial response as a highly predictable response, which is used as a signal for functional MRI measurements. So once the neuronal response triggered, then you could see the cerebral blood flow change almost immediately, right? So that response is actually disrupted in Alzheimer's. And in fact, severely disrupted, right? So to really generate that response, brain is highly perfused and it has endothelium lining all the brain blood vessels. And it is even said that every neuron in the brain is supplied by a capillary, almost very close to 10 microns in distance. So that's how much that's the kind of support that's required for neurons to function normally. So if you look at the section of a capillary here, you could see that the capillary is lined by the blood-brain barrier endothelial cells that are colored in purple. And then you have pericytes that are right outside in the basal lamina, and then astrocytes supporting and neurons taking a lot of support from pericytes as well as astrocytes. So all these four cells, endothelial cells, pericytes, astrocytes, and neurons, we call them neurovascular unit. So in neurodegenerative diseases, neurovascular unit is highly dysfunctional, right? So for the neurovascular unit to function properly, all these cells must be signaling with each other. And if the soluble factors like cytokines that are circulating in the plasma makes endothelial cells dysfunctional, then that signaling is disrupted. As a consequence, you don't have the neurovascular response that is predictable. Okay, so I'm just making this a little bit more dramatic here. In a normal brain, that communication within the neurovascular unit is very well coordinated. So blood-brain barrier endothelium is not only a major transport portal supplying glucose into the brain. In fact, that's the only way glucose gets into the brain. But then it also coordinates and modulates the signaling because endothelium actually senses whatever is going on in the plasma and triggers the brain of how the signaling should be adjusted within the neurovascular unit. So it is a super highway of material transport and signaling, right? So it transports glucose, and then a lot of growth factors like insulin gets into the brain via the blood-brain barrier. And then it all, like transferrin is another major example. LDL, HDL particles get into the brain. And also the amyloid beta protein, that is a metabolite in the brain, is also cleared by the blood-brain barrier primarily. So in Alzheimer's, we already looked at amyloid plaques accumulating in the brain. And indeed, the only targeted therapeutic option for Alzheimer's today is an anti-amyloid antibody. Of course, it costs $80,000 per patient per year, but mechanistically, that is the only thing that is supposed to have an effect. At least there is a 20 to 30% improvement in cognition. But everything else, or all the other drugs, are very symptomatic. They only provide symptomatic relief, right? So the reason why I brought up that discussion is because amyloid beta is considered as a major component of the pathophysiological chain that's observed in Alzheimer's disease brain. Okay, so if you look at the transcriptomics, the expression, the gene expression of looking at the expression of various cells belonging to neurovascular unit in the Alzheimer's disease brain, you could see that pericytes and endothelial cells are highly degenerated, which means that the vascular component of the neurovascular unit is degenerated, right? Suggesting the importance of vascular component in leading up to dementia. Okay, so in Alzheimer's, that communication is totally disrupted. So there is a traffic jam, which means that the glucose is not getting supplied to the brain. The growth factors are not entering the brain from plasma. So that communication is severely disrupted. And in Alzheimer's patients, the PET imaging data, we have two main ways to detect Alzheimer's, the live Alzheimer's patients in the clinic. One is looking at the glucose accumulation in the brain through 18-FDG scan. And then the other is looking at the amyloid accumulation in the brain via PIB scan. So this is the data generated by my collaborator at the Mayo Clinic, Dr. Vallo. Here you could see that the 18-FDG accumulation in the Alzheimer's patients goes down significantly. At the same time, the amyloid accumulation in the brain goes up. So the signal, the top one is the FDG, so 18-FDG signal, and the bottom one is amyloid scan, suggesting that amyloid accumulation goes up as the 18-FDG is going down. Okay, and this is the temporal pattern of various Alzheimer's biomarkers that were generated by Dr. Cliff Jack, again at the Mayo Clinic, very celebrated radiologist, neuroradiologist. So what is clear here, I would like to point out to some important things. In fact, amyloid beta accumulation in the cerebrospinal fluid is the first biomarker, first detectable biomarker in Alzheimer's brain. And then after that, it's tau. Remember, like we talked about hyperphosphorylated tau in the neurons, and then followed by changes in MRI, FDG, PET, and then mild cognitive impairment. So the time gap between when A beta started appearing in the cerebrospinal fluid and the mild cognitive impairment changes, the time gap is 20 to 25 years. So there is a huge opportunity for the clinician to interfere if there is enough evidence of what's going on, what's causing the neuropathological changes in Alzheimer's brain, right? So, so now the major question is, what is really happening within those 25 years, and what is making cerebral vascular susceptible to early damage? And there are, again, very clear evidences that the metabolic syndrome, cardiovascular risk factors could play a major role in disrupting the cerebrovascular health. So the saying goes in the United States that whatever is not good for the heart is not good for the brain, because they're very, very closely aligned. So you have in Alzheimer's neurofibrillary tangles, amyloid deposition, cognitive deficits, but the risk factors could include, for example, in metabolic syndrome like type 2 diabetes, you have insulin resistance and obesity, and the manifestations of those two diseases overlap, and type 2 diabetes is regarded as one of the major risk factors for Alzheimer's, right? So the risk is probably being carried by the cerebral vascular dysfunction. Now, in that perspective, gut dysbiosis also plays a major role. So I'm going to get to gut dysbiosis, but I just want to present why cerebral vasculature is so critical and cerebrovascular health is so critical for healthy brain function. Okay, now let's take a look at microbiota. In case if there is dysbiosis in the gut, how is that going to disrupt the brain function? If you look at whatever is happening in the gut, you have dysbiosis, so you have a lot of anaerobes increasing in number in the colon, and then causing inflammation. A lot of cytokines they cross the epithelial monolayer, because the dysbiosis causes leaky gut, which is again a very clinical phenomenon. And because of the leaky gut, the bacteria, pro-inflammatory cytokines, all those get into the systemic circulation. So when they're in the systemic circulation, cerebrovascular endothelium is exposed to them. Like, for example, TNF-alpha. If you inject TNF-alpha, you see a very clearly inflamed cerebrovascular endothelium. Similarly, if you inject lipopolysaccharide, which is coming from the bacteria, there is a clear inflammation of the cerebrovascular endothelium. So here, there are two sections to this image. Under healthy conditions, you could see that the blood-brain barrier is all intact, so protecting the brain from these pro-inflammatory cytokines that are getting into the systemic circulation. Whereas if then there is dysbiosis, these pro-inflammatory cytokines increase in concentration in the systemic circulation, so they disrupt the blood-brain barrier integrity. As a consequence, there is increased expression of VCAM1, and I'm going to go over what VCAM1 is going to do to enhance inflammation in the brain. So that VCAM1 ultimately increases microglial activity, and microglial inflammation is a major phenotype observed in Alzheimer's disease brain. So that's what is believed to ultimately cause neurodegeneration in the brain. Okay, so let's take a look at how VCAM1 handles the infiltration of leukocytes from the periphery to the brain. Right? So you have, this is the endothelial membrane. Under normal conditions, the VCAM expression is reasonable. Of course, it's a controlled inflammatory environment. So, but when it gets out of control, you have greater expression of VCAM1 on the endothelial cell. So the monocytes that are circulating in the systemic circulation actually binds to that VCAM1 through integrants. And then those monocytes go into the brain through the endothelial membrane via paracellular tight junctions. They enter the brain and then they trigger inflammatory reactions. So particularly in cerebrovascular diseases like stroke, Alzheimer's disease, and other neurodegenerative diseases like multiple sclerosis, you have significant amount of monocyte infiltration into the brain. And that's what is believed to be a major trigger because of the microglial activation and subsequent neurodegeneration that's observed. So if we, based on the literature evidence, it's very clear that VCAM1 is a major risk factor. And then here, based on the transcriptomics data, we can clearly see that the inflammatory pathway genes get upregulated in Alzheimer's disease brain. Here, this is the control brain, and here it is an AD brain. And you see here ApoE33 and ApoE34 genotypes. ApoE33 is a common allele. It's observed. It's commonly observed. Whereas ApoE34, ApoE44 alleles are considered as major risk factors. So in fact, these alleles describe 50% of sporadic Alzheimer's risk. So that's the reason why we looked at both patients. Inflammatory pathways are upregulated. VCAM1 goes up in AD patients. I'll wrap up quickly. And then here, when the microbiome has the soluble factors released into the systemic circulation, they actually act in synergism. There is a pathological synergism between A beta and those pathophysiological factors, and particularly upregulate VCAM1 and cause cerebrovascular inflammation. So there is right now, like I was talking about, how less interested pharmaceutical companies are to coming up with these therapeutic alternatives to modulate the gut microbiome. So the only aspect that people are working on right now is changing the diet. So here, this is a pilot study that was conducted on how diet could actually reverse the consequences of aging microbiome. So here you could clearly see that there is a clear separation in the microbial distribution between controls, which are labeled as CN, and in patients with cognitive impairment. There is a very clear difference in the microbial distribution here, which is demonstrated by this principal component analysis, which means that those populations are widely separate. They're very different. So these patients are provided with two different kinds of diets: American Heart Association diet, and then the modified Mediterranean ketogenic diet. So there is a clear evidence that the fungi that are present in the colon shifted when the patients are administered with modified Mediterranean ketogenic diet. And that shift in the microbiome clearly showed positive changes in amyloid beta distribution in the CSF and also other hallmarks of Alzheimer's disease. Right now, that's where we are at, mostly looking at the diet. But hopefully, when we start investigating the impact of various drugs on microbial populations, particularly by administering short-chain fatty acids that are made by microbes as therapeutic alternatives, we might be able to bring more positive changes and observe the disease modulation. But I think that's what is going to happen in the future. And for now, this work wouldn't have been possible without help from various collaborators at the University of Minnesota and at the Mayo Clinic, particularly neuroradiology and bioinformatics help. And then these two institutions are pulled together by the Minnesota Partnership for Biotechnology and Medical Genomics, who gave a large grant for us to investigate these areas. And thanks for your attention today, and I'm happy to take any questions if you still have some time.
Thank you, Professor Karunya Kandimalla, for the excellent lecture. May I ask Dr. Irangan Aranguda to present the talk on certificate appreciation. And also come for the group photo, please.